Namaste. After the antroconal polyp video, now we proceed with the ethmoidal polyps. Looking at what is a polyp, polyps are outpouchings from edematous mucosa of nose or the paranasal sinuses. They are painless, benign growths. Let's look at the site of origin. The ethmoidal polyps are mostly bilateral and multiple. They arise from the lateral wall of the nose. This is the lateral wall of the nose. They usually arise from the middle meatus. They appear as multiple and as grape-like. The common sites are uncinate process, bulla ethmoidalis, ostia of the sinuses, medial surface and edge of the middle turbinate. The cause. Looking at the cause, the most important cause is chronic rhinosinusitis. You can bunch these three as sinusitis. The other causes are asthma, aspirin intolerance, cystic fibrosis. Then you have three syndromes, the Carter-Jenner, Young, and Church-Strauss syndrome. The pathogenesis of ethmoidal polyps is really interesting. Here, due to an underlying pathology, such as chronic rhinosinusitis, collection of extracellular fluid occurs. Now, this extracellular fluid is accumulated in the areas of the middle meatus and the middle turbinate. Now, due to the fluid being there, these areas become edematous. And if this is an area which has become edematous, what will happen? Narrowing of the area will occur. So, narrowing of the area occurs. And what happens if you narrow a hose or a pipe while watering the plants? The velocity increases. So, there is increased velocity of the air passing. This principle here is known as the Bernoulli's principle. Due to increased velocity of the air passing, negative pressure is created. And wherever there is negative pressure, it pulls structures towards it. So, it pulls the mucosa of the sinuses. And when mucosa is pulled, a polyp is created. The polyp is first sessile. What do we mean by sessile? A sessile polyp is flat. Then, later, with time, due to gravity and excess sneezing, it becomes pedunculated. Now, what is a pedunculated polyp? It has a stalk. It's easier to remove pedunculated polyps. Next is the pathology. The surface of the nasal polyp in early stages is covered by normal epithelium. What is the normal epithelium of the nose? It is ciliated columnar epithelium. But later what happens is that metaplastic changes occur. These metaplastic changes turn it into either transitional or squamous epithelium. This occurs due to atmospheric irritation. In the submucosa, we can see large intercellular spaces that are filled with serous fluid. And there is infiltration with eosinophils and round cells. That's the pathology. Then, how is the patient going to present to you? The patient is going to be mostly an adult. But mind you, ethmoidal polyps can occur at any age, but usually it occurs in adults. And they are multiple polyps. So you can remember it as an adult presenting to you with bilateral nasal obstruction. This nasal obstruction is due to nasal stuffiness. This is the presenting symptom. Later, due to this nasal obstruction, he can also have partial or total loss of sense of the smell. We have seen that one of the common causes is sinusitis. So, due to associated sinusitis, headache can occur. And one of the cause was allergy. So, due to associated allergy, sneezing and watery nasal discharge can be seen. Sometimes even the mask can be seen directly protruding from the nostril. Looking at the signs on interior rhinoscopy, we can visualize the polyp. The polyp appears as smooth, glistening, grape-like mass, which is often pale in color. It may be sessile or pedunculated. Insensitive to probing means we can move the probe all around. It does not bleed on touch and it does not pain on touch. We also do probing of a solitary polyp to differentiate it from hypertrophy of the turbinate or cystic middle turbinate. Because in middle turbinate, we won't be able to move the probe all around. So that is in case of single solitary polyp. But mostly ethmoidal polyps are multiple and bilateral. In case of long-standing polyp, it can also present with broadening of the nose and increased intercanthal distance. A polyp may protrude from the nostril and it may appear pink and vascular. It can simulate a neoplasm, but it is not a neoplasm. Nasal cavity can show purulent discharge due to associated sinusitis again. The signs are appreciated so well that the diagnosis becomes clinical. But we do CT of the PNS also. Why do we do this? We don't do this to diagnose. We do this so that we can exclude the bony erosion and expansion suggestive of any neoplasm. This is because single solitary polyp can be associated with malignancy underneath. And this is important in people who are more than 40 years of age. So we must exclude the neoplasm by histological examination of the suspected tissue. And then CT scan also helps to plan the surgery forward. Okay, so we do CT of the PNS to see bone erosions, to see if there is any neoplasm, and to plan the surgery. That's all. Looking at the treatment, we have conservative and surgical treatment. So first is conservative. In early polypoidal changes, sometimes antihistaminics are very useful to control allergies. So if the cause is allergy, we can use antihistaminics. And also a short course of steroid can be given. Steroid is useful in patients who cannot tolerate antihistaminics and also in patients who also have asthma. Steroids can also be given after surgery to prevent recurrence. We have to also keep in mind the contraindications of steroids. We are not going to give steroids to people with hypertension, peptic ulcers, diabetes, pregnancy, and TB. So we have to exclude these diseases before giving steroid to the patient. Then the definitive treatment is surgical here. The first treatment is polypectomy. In polypectomy, we are manually removing the polyps, right? We are removing them with a snare. So this is done when only one or two polyps are present and they are pedunculated, because I have told you that pedunculated polyps are easier to remove. But if there are multiple sessile polyps, then we require special forceps for that reason. Next, we have intranasal ethmoidectomy and extranasal ethmoidectomy. We do intranasal ethmoidectomy when the polyp are multiple and sessile, and we do extranasal ethmoidectomy when polyp recurs after intranasal ethmoidectomy. And what is the route of extranasal ethmoidectomy? The route is through the medial wall of the orbit by an external incision which is medial to the medial canthus. Next we have transantral ethmoidectomy. As the name suggests, it is through the antral. So it is by Caldwell leg approach. We do this when the infection and polypoidal changes are also seen in the maxillary antral. And the most important surgical procedure here is endoscopic sinus surgery or FES, functional endoscopic sinus surgery. This is the most preferred method now. This is done with endoscopes which has angulations. Thank you. If you don't want to miss my next video on differences between antroconal and ethmoidal polyp, please subscribe. Thank you again.